Hello, this is Tiziano Barbui. I'm talking today about MPN and COVID-19. What have we learned so far about this disease? So the European Leukemia Net study in patients with COVID-19 decided to collect patients with MPN during the first wave of the pandemic, meaning from February to June 2020. The aim was to generate knowledge in the real world management of these diseases. I'll try to answer two questions today for you. The first is whether patients with MPN are at higher risk of dying in comparison with the general population. The second, whether patients are at high risk of thrombosis and bleeding. Patients we collected were 180. We had to remove two patients because at the time of this analysis, they were patients with acute leukemia. So we decided to make an analysis of patients with MPN during the chronic phase of the disease. From Italy, Spain, France, UK, Poland, and Germany, we collected 59 patients with essential thrombocythemia, 57 with PV, 39 MF, and 23 with pre-fibrotic myelofibrosis. And you see here that Italy and Spain were the two major contributors to this series of patients. Age of these patients was about 50, 70 years old patients. This is the age of patients with the MPN. We had information about the mutation, JAK2 CALR MPL mutation. The therapy of patients with COVID depended on the severity of the disease. We had about 60% of these patients who needed to use respiratory support. This was non-invasive or invasive, meaning that they had to be transferred to intensive care unit. Drugs used during the hospitalization were hydroxychloroquine, antiviral, some experimental drug, but please notice that not all patients were using antithrombotic therapy. Only 60% about they were on antithrombotic therapy because at that time, at the beginning of the infection, of the first wave of the infection, we didn't know that one of the major problems of patients with COVID was thrombosis. And in the cases where antithrombotic therapy was used, heparin was almost in all patients the drug that was used. Some patients were also on DOACs, direct oral anticoagulants, some on warfarin. The cytoreductive drug of these patients used in ET, PV, MF, or pre-PMF mainly were hydroxyurea and ruxolitinib. Especially hydroxyurea was used in ET and PV and pre-PMF, whereas ruxolitinib was very used in patients, 60% in patients with myelofibrosis. So the overall survival of these patients was very poor. As you see here, in the first month, we register a mortality in 25% of patients, so that during the observation that lasted 60 days, the overall survival, those patients who survived were 68%. So overall mortality was 30% about. Particularly in myelofibrosis. You see here in myelofibrosis, 40% of the patients died. And the reason for dying were vascular deaths, pneumonia, or multi-organ failure. All this data have been recently published in the journal Leukemia. You can see all this data in Leukemia just published. The overall survival was, of course, different according to patient disposition. The overall survival was very good in patients who were managed at home, was less good for those patients who were treated in a regular ward, was very bad for patients followed in intensive care unit. You see here is totally different, because in intensive care unit, survival was about less than 50% of patients. In a regular ward, 25%, 75% survived. Almost all the patients staying at home were well, and only very few patients died during the observation. So it depended on the severity of the disease. Multivariable analysis, you have to do multivariable analysis when you have many factors that can contribute to the mortality rate. So we select in this statistical technique that is called multivariable analysis, we selected some variables that are known to be important for determining the death of these patients. And you see here what is important is the sex. Male sex was more, there was a propensity to die for males in comparison to females. Whether the patient were in intensive care unit, but very, very important message for you is the great majority of patients who died was those who discontinued ruxolitinib during the infection. So we have three main factors that contribute to mortality. First, to be male. Second, in the intensive care unit, meaning that severity of the disease, and very important, ruxolitinib discontinuation in myelofibrosis. And you see here the survival curve. This is the survival curve for those who were on hydroxyurea. This second was for patients who continued ruxolitinib during the observation, during hospitalization, and this is the poor survival for patients who withdrew, who discontinued ruxolitinib during hospitalization. Virtually, with this new technique, all patients died within 15 days after admission to the hospital if they discontinued ruxolitinib. So the message is ruxolitinib should not be discontinued. And the reason for that is because during this disease, you observe a so-called cytokine storm. So during the COVID infection, you have a release of many cytokines that are derived because the virus, this is the virus, attack cells, cells in the lung, cells in the heart, in the kidney, in the intestine, lungs, liver, blood vessels, and also in the brain. And there is a release of cytokine. And this enormous release of cytokines is called cytokine storm. And the cytokine storms can be controlled by ruxolitinib because this drug has a potent anti-inflammatory property, because this drug acts in the cells by inhibiting the release of these dangerous cytokines. So, in conclusion, collected under condition of exceptional COVID period, we observed a great lethality. Lethality was higher than in general population, and was particularly higher in myelofibrosis, and this was due to discontinuation of ruxolitinib. The second question was concerned about thrombosis. In COVID-19, thrombosis is a frequent complication. The thrombosis, particularly in venous thromboembolic complication and myocardial infarction, ischemic strokes. And by autopsy findings, it was found that many patients died as a cause of microthrombi in multiple organ systems, including lung, heart, and kidneys. I told you about the cytokine storm in these patients. So the cumulative incidence of thrombosis, considering death as a competing event, because in these patients, you see, this is death. What could be the rate of thrombosis excluding death? This is the rate of thrombosis during the observation of patients with MPN. Adjusting for death, the percentage of patients who develop thrombosis was 8 to 9% after 60 days. And the overall rate was different according to the severity of COVID. 1% for patient at home, 3% in a regular ward, but 18% in patients more severe that needed to be admitted in intensive care unit. What we observed was that venous events were more frequent than arterial events. Venous events mean pulmonary embolism associated also with the deep vein thrombosis and also splanchnic vein thrombosis. And these events occurred very soon after patient hospitalization. In the first week after hospitalization, and was about 5% in PV, MF, but was 16% in essential thrombocythemia. So the more frequent disease, MPN disease, associated with venous thromboembolism was found to be essential thrombocythemia. And this is the cumulative curve of events. You see here this curve. Maybe you can follow my arrow, and is very, very high in the first days. It reaches 17% in the first month. On the contrary, in other MPNs, in PV or in MF, you see here that the rate is very low as compared to essential thrombocythemia. So 17% versus 5%. You have to notice that very soon is the thromboembolism was diagnosed after the hospitalization. And this was in spite of heparin, So also in this case, we did a multivariable analysis. As I said, when you have many factors that can be causative of one event, we adopt a technique, statistical technique that is called multivariable analysis to pick up those variables that are independently associated with the event. In this case, the event was thrombosis. And once again, the severity of COVID was associated with thrombosis, but also the severity of inflammation. This ratio, neutrophil lymphocyte ratio, is a sort of determinant of the cytokine storm, as I told you in the first slides before this one. And of course, the phenotype ET. So ET, essential thrombocythemia patients, are independently of the fact that you are in an intensive care unit, or if you have a cytokine storm independently, to be a patient has a propensity to develop thrombosis during COVID, 4 times higher than polycythemia or myelofibrosis. But what we observed, very important, is a platelet number, but it is also the consumption of platelet during the infection. You see here in the first 2 columns, you have the number of platelets at hospitalization. 326,000, but the day of hospitalization, you have a decline of patients, 23% of this decline. And this decline was particularly seen in essential thrombocythemia. And this was correlated with pulmonary problems, especially pneumonia. So we suspected some role of platelets for thrombosis. And this is particularly more important in COVID-19 comparing with other non-COVID infections. And this is due to the fact that the platelets can trigger an hypercoagulation, and this could be associated with increased concentration of coagulation factors and so on. And at the end, you have the clot in the vessels, you have a clot also in the lungs. So in conclusion, overall, the cumulative rate of thrombosis events was 9%. Most of the events were venous events. And you know that in MPN, not in COVID, but outside the COVID, the most frequent thrombosis are not venous thrombosis, are arterial thrombosis, are stroke, myocardial infarction, microvascular thrombosis, but not venous thrombosis. In this case, venous thrombosis are most frequent. In patients with a PV and MF, the rate was 5%, whereas in ET was, in the severe cases, 18%. This finding highlights the role of platelets. So the decline of platelet associated with the number is very important, and it was found to be associated with respiratory deterioration and pneumonia. And this could be the cause of in situ pulmonary thrombosis secondary to lung inflammation. And this is called immunothrombosis. So we are doing other studies now, starting from this first wave of pandemic observation. Two studies, as I said, 2 additional years of observation. So we reopen our registry to recognize other unmet clinical needs and to confirm also this observation that have a very important impact in the clinical practice, because for the first question, we answer a question. That the question was whether we have to discontinue drugs during the inflammation, infection, and the answer is no, please. Don't suspend, don't discontinue ruxolitinib, otherwise you generate a cytokine storm. The second is the thrombosis in ET. So we want to enlarge this series. And the second question, what happens in surviving patients after 6 months after discharge from the hospital? And we are completing now a study trying to answer this question, whether there are sequelae after the discharge from the hospital. So let me acknowledge the European Centers for their enthusiastic collaboration, patients and families, and all my co-workers, and the Foundation for Clinical Research for allowing us to conduct these studies, and you for listening. Thank you.